let's take the kind of newer indication on the block, lutetium, right, 177. So we've gone from a post-chemo to pre-chemo label indication for that. Have you had patients on lutetium? I assume you have. And then what's been your experience with that?
Yeah. So fortunately, I've not managed any that are directly on it, but some of my other patients that I see loosely have been. And, they're at the point that they're on this, they're kind of done already, right? So a lot of the patients historically that had received chemo, this was their last resort. They're worn out, fatigue significant. And now we're treating them a little bit earlier. So I'm hoping we're going to see kind of a different face of lutetium with these patients that aren't at the very end. So I look forward to seeing how those patients, hopefully getting them in early is going to show us the benefits of that drug, maybe a little bit more.
Yeah, I've had some that have progressed, and they progress radiographically and serologically, and I go between, do we hit the oligometastatic disease with radiation? Do we go with lutetium? The sequencing, Rob, do you have any thoughts about that? I mean, have you had folks on lutetium?
So when it was post-chemo, I had a couple of guys, and like Brooke said, they were, later in their disease state and pretty low ECOG status. So they did not do very well. I've had a couple of folks that that got chemo up front years ago, and so they were technically post-chemo, but they hadn't seen chemo or taxane for, 5, 6, 7 years. And the few of those that I've had, they sailed through lutetium. They did great. They still had a good performance status before, they still did afterwards, and they compared it back to their chemo, 5, 6 years ago and said it was much easier than that. So those folks, I think, do pretty well. I haven't had a new patient who has not had any chemo yet. I've not had one of those patients yet, or managed them if they've progressed or afterwards. So I haven't seen that yet. But I think in the patient that's fairly well, it's not too beat up, I guess is what I would say. They do fairly well.
So Steve, somebody comes in and you've had them on doublet therapy. They've got soft tissue progression. No bony meds, can't really give them radium. They really don't have any HRRT mutations. They're not really a good PARP candidate. And they're progressing. Where are you going to go with that? Are you going to go chemo first? Are you going to go lutetium first? Or how do you breach that conversation with the patient?
Well, I mean, there's more data obviously out there with chemo around. Yeah. But it's not that it's that great. It's just that there's more data. And I'm kind of excited about the pre-chemo lutetium at this point. I think I've had 3 patients on lutetium. They were all worn out, and then they all passed. I mean, they didn't do well. But the question was always, how early in treatment can you give this and see if you can make a difference? I mean, if you were the patient and I was talking to you, I would say this is the current data based on chemotherapy. This is what you can expect. You're a good performance status, so you're likely going to do well with whatever we give you. But this is newer. There's not tons of data on it yet, but this has certainly potential.
Yeah, it's kind of funny. If you get some of these patients, if you get a rad onc involved, guess what they're going to get? Lutetium. If you get a med onc involved, they're going to get docetaxel. So we're in this unique situation where we're kind of gatekeepers a little bit of that because we're not giving the medicines, we're referring them out. Do you have any thoughts about that, Brian?
Yeah, I think it's challenging. I think what you're saying. So yeah, I kind of just try to get everybody, have them see actually each discipline and kind of try to weigh all their options. And yeah, I don't have a lot of experience with lutetium yet, so I think you just got to give them their options. And yeah, it's great that we're trying to move this stuff earlier. I think is the key, giving it earlier than we were before.
Yeah, I've seen some great responses with that. I've seen also some toxicity, salivary toxicity, especially. Have you?
Yes.
What do you tell your patients in terms of that? Do you tell them up front, hey, listen, be aware of that?
I definitely make them aware of it even before we put the referral in. And some people have it, some people have it profoundly, some people don't have much of it. But yeah, I mentioned it up front for sure.
It is, you're exactly right. It's strange. I don't know how to predict who's going to have more, and I don't know that there are anything out in the literature about it, but it can be kind of a significant thing for us. So, so Brooke, if somebody coming in, 62-year-old person comes in with a Gleason 7, and they have some positive bone mets, 3 positive bone mets and a PSA 57. What's your initial? They have 3 positive bone mets on conventional imaging. Where are you going to go with that? What do you think? So, healthy guy, Gleason 7, really high PSA 57, 3 bony mets. How are you going to? What do you think?
Yeah. Well, as far as again, need germline testing. Talk through that. Again, check that box, right? Because we're supposed to do it. We're trying to remember. And then good ECOG status, young guy, right? So at that point, trying to talk through doublet if it's just a couple bone mets therapy, see if they're open to it. You know, again, I like to talk to patients through all options.
How do you address their primary, the primary tumor? You know, because if they're coming in just kind of de novo with that, do you think they need to have primary control with surgery or radiation?
Yeah, because I think that's probably where they're going to get most of their trouble from, right? So, in a young guy, whether you're talking about, you know, do you want to still consider surgical options for them? I mean, most of the time, I think we immediately say no with those bony mets, but still discussion. And then with radiation, if they don't have anything else going on in the pelvis, you know, talking about what those options are to include the bony field, if you can, versus, you know, starting them still on systemic therapy.
Would you take someone's prostate out with that?
I consider it, especially if they had urinary issues. I mean, if they're, I would certainly consider it. Yeah. It's not the wrong thing to do, that's for darn sure. Radiation is also a viable option. Radiate the bony mets, you know, the small volume metastatic disease, radiate the prostate. But if they've got urinary issues, bladder issues, yeah, why not?
Yeah, if they're 62, I think they're going to have local control issues. You know, if we have the ability to have them live long enough and do that. So Brian, we get a PSMA scan, and now there's 10 mets, and now it's not in the pelvis, but it's in the spine, and there's like clavicle. Does that change how you want to do local control on that person, or not really?
Yeah, typically it does. You know, I do sometimes wonder if it would help if they have low, you know, because you feel like you're not treating the source. But yeah, usually I would just try to push them toward triplet therapy. You know, after you get the genetic testing and yeah, I would kind of push them to triplet therapy.
Okay.
Some of these guys I've seen lately who did not have local control. This was more, you know, they started their journey 7-10 years ago. We weren't radiating the primary, we weren't removing it, that sort of thing, but they had bad disease to begin with. We've got pretty good control over their bone mets, their lymph nodes, etc. But then all of a sudden, they get like some hydro, and you're like, oh, that's kind of strange. But their PSA is basically undetectable or stable at a low level, and then you get a scan, and there's a mass down there, and now it's neuroendocrine transformation.
Right.
And so, could you have avoided that if you had treated their primary up front? Because then that leads to significant morbidity associated with nephrostomy tubes and stents and catheters and bleeding and all sorts of other things. So I think we're kind of seeing the lack of primary control show up because we've kept these guys alive for 5 to 10 years in some instances.
Yeah, yeah. I definitely think that that's true.